if you've got access to the chat, please do let us know where you are. It's to Maureen's wonderful point about 19 countries. We have people from 36 different countries on the CC list, or the BCC list, as I'm careful to do when I send this round. It's always wonderful to hear from where people are at. So Karen's in Berlin. I love it, and I love the fact you've dialed in. And I always get confused exactly where Lisette is, with multiple links to all sorts of continents and countries. So do come and say hello. You still haven't told me, Lisette, where you are. Ha 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 is not a place, I'm sure, but it'd be great to hear from you all. And Dundee, what a beautiful place. I suspect that was cold today. So great to hear from you all. Do say hello on the chat. This wonderful community really works because of all of you. And just for those of you who didn't get a chance to have a proper look at the little email that I sent around, I've just put this little link in the chat to a really interesting report that a friend and colleague called Alex Fox did, and great credit to Suzie Bailey, who if ever you write a report, is busy reading the detail on page 15. Page 15, as Suzie says, we get a lovely mention, and Alex was thrilled. I told him that I'd sent it out to everybody here, was really thrilled about that. So important bits of connecting, and great. And we've got David here. David from a snowy and icy Dorset. Great, we've got your proper email address. Right, listen, I think time to crack on. I'm hoping that Nikki is free and with us to join, because I think Nikki's going to do a quick intro for Rich, although Rich is a great friend of this community, doesn't need much introduction. Nikki, are you there, is my question.
Yes. Hello, everybody.
Over to you.
Can you hear me?
We can hear you well. Yeah, go for it.
Wonderful. So it's my great pleasure to introduce Rich, but I also have the great pleasure of introducing my young daughter, Emily. For those of you that know me well, Emily is the reason for the season, why I'm weeks off submitting a PhD in kindness. So Emily's a little mini celeb. She's going to be with us for just a few minutes, but she wanted to say hi. And now on to the main star of the day. It's a real honour for me to introduce Professor Rich Frankel. He won't need much introduction to many of you in the group. And certainly Rich, for me, has been a lovely friend and a big support as I've traversed this PhD journey. Rich is a Professor of Medicine and Geriatrics at Indiana University School of Medicine. He's a senior scientist at the Regenstrief Institute. He currently directs the Advanced Scholars Program for Internists in Research and Education. Rich is a qualitative health services researcher. His interests include face-to-face communication and its effects on quality, safety, and outcomes of care. And I'd strongly encourage you to plug Rich's name into Google Scholar and take a look at some of his amazing publications in that area. More recently, he's been using approaches from the positive social sciences to change the culture of academic health service centres. He's been a medical educator for the past 40 years and is a co-program director, or served as a co-program director in the internal medicine residency program at Highland Hospital, University of Rochester. He's published over 300 research papers in the area of physician-patient communication and organisational change. Rich, it's such a pleasure to have you here with us today, and thank you very much for being our star speaker this month.
Well, thank you for that introduction, Nikki. I sit here and wonder, who in the world are you talking about? Because the lived experience is very different from a CV. In any case, thank you for the warm introduction, and welcome to the community and friends. And so today I'm going to be talking about things that we can do from the other side of the bed rail, meaning as patients receiving healthcare services. And the story I want to tell starts really in 1959 with Renee Fox, who was researching the socialization process for medical students. And she concluded that students share the conviction that admitting to having strong feelings is not in keeping with the standards of professional objectivity. And she called this phenomenon detached concern. That is, managing to stay objective in the face of great suffering or in the face of strong emotion. And that approach to socialization has really been the watchword for how we train medical students and residents. It's really not until the turn of the 21st century that we begin to see another framework emerging. And this is one that was published by Jody Halpern, who's a psychiatrist in San Francisco, in which she argues that it's important to move from detached concern to empathy, and shows how empathy can be used to good effect. And this relates to the second thing that I want to talk about, which is the consequences of detached concern.
I had to.
And one of the consequences is physician burnout. And we know that the elements of burnout include things like detached concern in the face of strong patient or provider feelings, emotional exhaustion, feelings of decreased personal achievement. Here in the US, burnout has reached epidemic proportions, not only for physicians, but across the health services professions, across the health service professions, with nearly 2/3 of physicians reporting at least one sign of burnout per week. Why do I bring this up? Well, I bring it up because when we go in for healthcare services, we may be dealing with people who are under tremendous stress and are distressed despite our expectations for care. And just to say it out loud, my expectations for care are, in a perfect world, I expect to be listened to and respected, to be treated with kindness, to be attended by people who are technically proficient and engaged in their work, and to receive clear explanations and collaborate in making plans, both short and long term, for my future. So the question is, what happens when my expectations aren't met? And I think until a few years ago, it was mostly negative, that if my expectations weren't met, I would get frustrated, maybe feel disappointed, maybe feel anger, and some resentment that the people who are supposed to be meeting my expectations aren't. So the story continues. This is September 16th, 2021, during COVID. This is the triage room of a 32-bed community hospital about 15 minutes from our home, and a room into which I was wheeled having crushing substernal chest pain. And the things that are worth noting, this is the actual photo of the actual room, the things that are worth noting are just how much technology there is in this room and how devoid of anything more humanistic or humane the room has. So if you're anxious or you're in a lot of distress and all that surrounds you is technology, it might be a little off-putting. But I was fortunate. I was really fortunate because the first person to see me was a hospitalist. And the first thing that she said after welcoming me was, "I know all about you." I'd never met this person before in my life. She said, "I read your internist notes. how's the book on exam room computing that you've been writing? And I nearly fell off the table and said, well, we put it on hold for 6 months because we were on sabbatical in France. And that started a relationship that has actually continued to this day, that the internist, the hospitalist, was able to create the conditions to transform what was otherwise a cold and uninviting room into a place of safety, into a place of kindness, and into a place of relationship. Well, having received kindness from someone who otherwise might be under a lot of stress was really eye-opening. And in my teaching, we had used a question that Fred Platt, a good friend and colleague, had published, when he said that the best first question you can ask a new patient is, tell me about yourself. And I decided, since I had received kindness, I was going to try an experiment of using kindness with each and every healthcare professional I dealt with. And so I want to tell you 3 quick stories about the care that I received and what asking healthcare professionals to tell me about themselves produced. The first is Adaya. Adaya was a housekeeper. And as I was moved from the emergency room up to the floor, she was actually the first person I saw. And she was cleaning my room, and I said to her, tell me about yourself. And she said, well, I moved here 7 years ago with my 3 children. I'm from Nigeria. And I first came to the United States and landed in Baltimore, where I worked for a shipping company. They went out of business, and I had a cousin living in Indianapolis and came here and started working here. And I said, tell me about your work. And she said, with great pride, I love what I do. It's my opportunity to make sure that patients remain safe and secure in their hospital stay. And so for the 3 days that I was in the ICU, Adaya and I had an ongoing conversation each of those days. The second encounter was after my second heart attack, which happened in Sarasota, Florida. And again, I was in the ICU. It was 4 o'clock in the morning, and a young nurse came into my room to take my vital signs. And I said, tell me about yourself. And she said, well, I just moved here from Maine, and I finished my nursing degree there. And I came down to Sarasota because I can make a lot more money as a traveling nurse than I can in Maine. And I noticed underneath her bicep, or tricep, I should say, there was a tattoo. And I said, tell me about your ink. And she looked at me and she said, well, that was the last sentence that my boyfriend wrote to me before he died. And I said, I can't read it. Would you tell me what it says? And she looked at me and she said, it says, I will love you forever. And at 4 o'clock in the morning, we locked eyes. We each got a little misty-eyed. She didn't need me to take care of her, but we just made a human connection. I didn't see her again for the rest of my hospital stay, and I probably will never see her again. But I'll never, ever forget that moment and never forget what we shared in that moment. And the third example was after my third heart attack, and I'll stop there because I've only had 3 heart attacks, thank goodness. And I was again in Florida and wound up having chest pain and rushing down to Sarasota Memorial Hospital, where I was rushed into the cath lab, the catheterization lab, and a cardiologist introduced himself to me. And he said, we're going to administer some medications, and I want you to start counting backwards from 100. And I think I got to 97, and the next thing I remember, I was in a recovery room and then moved up to the floor. The next morning at 7 a.m., the cardiologist was doing rounds, and he reintroduced himself, and he said, do you remember any of our conversation in the cath lab? And I said, honestly, I don't. He said, so you don't remember asking me not once, but twice to tell you something about myself? And we both laughed, and I said, no, I have no memory for it whatsoever, but no time like the present. So why don't you tell me about yourself? At which point he told me about his origin story, that he was a first-generation Indian, the first to go to medical school in his family, trained in Pittsburgh, then Boston, then came to Sarasota, was raising a family, so forth and so on. And after about 10 minutes, he was about to leave, and he looked at me and he said, you know, in my entire medical career, no one has ever asked me to say something about myself. And I really want to thank you for that opportunity. So here we have 3 quick stories out of dozens, because every single person that I asked to tell me something about themselves did, whether it was short and sweet or whether it was deeply self-disclosing. Every single person was willing to talk about themselves. So what I take from these experiences is that if our expectations aren't being met, and if the situation is one where we're dealing with people who are burned out or under a great deal of stress, are there things that we on the other side of the bed rail can do to humanize the encounter? And I think the answer to that is yes. And I'm not alone. I have a good friend who recently retired as the dean of the nursing school at the University of Virginia, who was going in for a serious back operation. And when I told her about my experience, she said, I'm going to try the same thing. And she came out with exactly the same results. When she encountered others in the hospital that she was in, and she wasn't in a hospital where she was known, people were more than willing to talk a little bit about themselves. So with that, here's the provocation for us to move into small groups. I'd like you to think of a time when your expectations for service were challenged and you, there's a word missing there, you were transformed, or you transformed the situation by demonstrating kindness and empathy toward the service provider, especially in situations in which your expectations for care were not being met. And then question for discussion or reflection, what was it about you that allowed kindness to emerge? That is, of the things that could have happened in that situation, what quality or characteristic was it about you that allowed it to emerge? And what was it about those around you? Was there something about those around you that encouraged kindness or encouraged you to change the situation? And was there something about the institution or organizational culture that encourages kindness in the face of distress? So, Bob, I am hoping that we can put people into small groups.
We certainly can. Rich, this is teamwork. Listen, thank you so much. What an amazing provocation. I'm going to put in one tiny reflection that I'm curious about. People will come in. I think back 25 years ago when I first started as a doctor. I'm really convinced we were taught actively not to do what you're describing and what you're saying. And I'm curious about that and what's going on. And there's an awful lot of educators on this call, and very experienced ones, and all of us still currently doing stuff. There's something for me about the education lens that just is worth us thinking about. Anyway, listen, let's get into rooms. We are gonna usual story, really. Put on a seatbelt. It's going to take about 10 seconds to get through. If you get lost in the ether on the way, if you have a total tech nightmare, leave the call, rejoin. I will be waiting for you like some sort of not very good airline assistant to find you to a new seat. But if you do get lost in things or you have tech issues, please shout. But otherwise, and Rich, what do you think? Should we do maybe about 18 minutes? Should we go to 20 to the hour?
Yeah, that would be great. And let's not lose that question that you asked, because certainly in the 40 plus years that I've been a medical educator, I have taught explicitly that if a patient asks you a personal question, you should reflect it back to the patient and say something like, this isn't about me, this is about you. And I'm willing to say that after 40 years of teaching that, I was wrong.
Yeah. Isn't it wonderful to be wrong? We'd go well beyond 20 to the hour with my list of things. Listen, Rich, thank you. It's something, yeah, super interesting, isn't it, for us? Listen, what a wonderful thing. Right, we're going to go in 2 rooms. So let's see what happens, and we'll see you back at 20 to the hour. I posted the questions in the chat, so you've still got them, and I'll send them as little announcements so they get into your subgroup as well. So let's see what happens,
right.
And we'll see you all shortly. You, you lovely people might have just got really unlucky. Lucy, you must be cursed, is all I can say. There's something about your, I don't know, email address or IP address that means you get stuck with me. I think we've got the Renegade breakout group in the main room. So if everyone's happy, we should just go for it. This looks like an absolute perfect group. I hope if you keep an eye on the chat, you should have our questions there. But it'd be great. I've heard too much from me. Come on, who's gonna? Kathy, you've got your mic off. Nigel's got his off as well. Kathy, why don't you go first? Nigel, why don't you follow? It'd be lovely to hear from you. What do you think? What did you make of that?
I loved the initial talk. Beautiful. And I'm thinking in my 20 plus years as a physician, I have had just a handful of people ever ask me to tell them something about myself. And I'm not sure that I've ever diffused a situation in my own like patient care area. So sorry, I'm gonna hit mute. Somebody else share what they've done.
Great stuff. Thanks so much. Nigel, so lovely to see you, and it was great to connect up on the chat. Where's your thoughts on this?
So I mean, this may or may not be the same sort of thing, but this is the 2nd anniversary weekend of my father's passing. He was admitted to hospital with what was thought to be heart failure, and to cut a long story short, he ended up having widely metastatic cancer and died very, very quickly in hospital. And there was a second-year doctor, and my daughter, who Bob joined us on one of these calls as an F1
yeah, I remember,
not long ago, was with me in Belfast, and the young doctor found herself alone effectively on this ward, not expecting to be looking after somebody who was as unwell, because it was a cardiology ward, and the CT scan result had arrived, and it showed this unexpected bad news, and she was clearly in a bit of a state with no kind of support. And so I find myself in a position of kind of saying to her, look, I can see that this is and almost sort of talking to her about how she might approach that, fundamentally founded on the principles that you espouse here. And that the real thing for my dad, who wasn't medical, was be kind and be clear. And that if she was able to be kind and be clear, that would be the thing that would really help him and help her. And she was magnificent, this young doctor, but just you could almost see the fright in her eyes, and just supporting her with how she might approach this problem that she'd not really wasn't expecting, certainly on that day, and maybe hadn't encountered, and just the clarity of just be kind, which she absolutely abundantly was, and clear, because often I think going back 25 years ago, there was a lot of there was a lot of us hiding behind big words and all the rest of it, but and what it did was it empowered my dad to make decisions for himself over the next few days, which subsequently helped us, because he understood what his position was, what choices he had open to him, and so it unlocked an end of his life that I look back on with great fondness now, because he was able to be in charge. We were able to be with him. He was lucid, right to the end. He got phenomenal palliative care. So that act by that young doctor really unlocked something really remarkable.
Well, Nigel, what an amazing story. Thank you so much for sharing, and your amazing dad will be listening in, thinking what the legacy in a way of that. And to your great, the humility and courage, but also just leadership and event for you as this, the son of the carer, to just spot that. It says everything about you, but it does play to this thing about the environments we're in to allow people to thrive. And that's what you also, through leadership, created an environment where this young doctor was able to just do something amazing, but with that elegant simplicity that you described. Thank you so much. I'm not surprised Lucy and Sarah are going to come piling in on this. I mean, Lucy, you're there with super senior role, responsible for operations across a whole great sets, a hospital and wider system. How do you create these sorts of what I love having so many people in this call, but you bring that sort of humanity to that ops piece. Tell us a little bit, you're creating environments to allow Nigel's story to happen.
Well, the story that this conversation has prompted in me, I'm not sure if it's quite the right way round, but anyway, I'll tell it. In the last hospital I worked in, it was actually Royal National Orthopaedic Hospital, which anybody that kind of knows that organisation, it's full of orthopods who famously probably not the kindest of specialties, and during COVID, kind of queuing in the canteen, one of the very few, she was a female consultant, and there were very few female surgeons there, kind of turned around to me and said, we were just in the queue, but how are you? Are you okay? To me, as the chief operating officer. And I was kind of like, I was so taken aback to be asked that, because, in a sense, I was a bit like how doctors are supposed to be, the one somehow in control of the situation. That, it just opened up a set of conversations between us that would have not happened otherwise. You know, just the simple of humanity of saying to me, how are you? You must be exhausted. I was like, you're the one on the front line. You know, they were in their PPE, they were in their, you know, I was kind of, yeah, I was busy. I was, you know, and we were all in situations we'd never been in before and unprecedented. That's probably why it allowed that conversation to happen so quickly in such a human way. But it's that same sort of the disarming, you didn't expect that, or I didn't expect that level of, you know, kindness or consideration for me. As the first part of the conversation, that, you know, and I just, you know, it's one of those standout things. I mean, in terms of how do I try and, you know, how do I introduce, you know, humanity and kindness in the ops world? The best I can say it's by role modeling it. I mean, I don't always get that right. I know when, you know, when there's a lot of pressure, I can feel myself getting more and more frazzled and not, you know, and ratty and expressing my, frustration with the way things aren't going the way that they need to, and that, you know, I have to have internal conversations with myself about, you know, just remember that you know, everybody's looking at you in, you know, in these teams that you lead. And, you know, in fact, another doctor said to me, you know, on those site meetings that we do every morning, if you're not in a, you know, if you're kind of expressing displeasure, it sets the tone for the whole day for this organisation. I was like, oh, you sometimes just have to be reminded of the extent to which, you know, if I smiled or I frowned or I, you know, the extent to which people notice and are led by that.
Really,
it's quite
really
scary.
Well, yeah, and both your stories also, you both use a bit about unlocking, and I love that bit about how some very small framing acts focus can unlock stuff. Sorry, you've been super patient. Come on in and welcome as well to Manjula and Ranjit and Sheila. Hi, you guys are sort of joined midway through a breakout. We're in the breakout in the main room. Just you'll love the conversation. So tune on in, and we're at about 22. We'll come back to the main room. Sarah.
Okay, it's Sarah, actually. It's Sarah without an E.
Apologies.
No problem. You're pronouncing as I would expect you to, but I am actually a Sarah without an H. So what Rich has said is 100% spot on, and I'm not surprised by it, because it's exactly how I've sort of been. I'm a patient. You know, I'm actually a patient partner. I've worked very much together with the NHS over the last 10 years developing patient partnership. But I have lived with cancer for the last 14 years. First of all, a breast cancer, and then just about 18 months ago, devastatingly now, a standalone incurable lung cancer. So I've actually had a huge amount, plus my husband had mouth cancer in 2020. So I have got significant experience of healthcare, and absolutely wonderful, wonderful people. But what I do right from the very beginning is I look at everyone I come across as a person. You know, how can I be asking people to, you know, look at me as a person if I'm not looking at them? For me, one of the greatest communication builders and an always event in my view is the hello, my name is. Because within 10 seconds, especially if you've got your name badge as well, so you get it visually and verbally and not just swung round, as a lot of you have on the lanyards, a bit awkward at groin level looking around there for it as well. But that is an icebreaker which happens instantly. You can see how people's stress goes instantly. As soon as that, almost in the olden days, gosh, I'm sounding old at 64. In the olden days, it was a shake of a hand. When you touched flesh, you thought, you know, we've got a bit of a building of connection. Now it's a verbal introduction. And that is absolutely it. Now, when staff, because I am going to say that whilst a lot of people are really good at introducing themselves, a lot of people need to keep working on it. What I actually do is I role model my expectation. So I'll say, gosh, yeah, I'm Sarah Tull, and who are you? And, you know, what do you do? So I'm not going in saying, you know, yeah, actually, this is my expectation. I don't believe anybody should ever not know who anybody in healthcare is who is treating you. But I go in, it's working together. My philosophy is do with me, not to me, together. Everything that Nigel said about his dad and about the fact that I expect to be part of the discussion, I expect to be part of everything. And what I can say is, as you know, so I work hard at my relationships, and my goodness me, what fantastic care I have received and continue to receive. And the other thing I really do is I recognize the pressures that staff are under. So, you know, I'll go in and, you know, I'll say, oh my gosh, goodness me, you're incredible, even more busy than normal or what have you. And somebody will say, oh, I'm so sorry. I said, don't worry. I said, you know, you'll get to me, you know, all that sort of thing. So it's really, for me, it's about seeing us as working together, as people together. And I've had some of the most wonderful conversations at nighttime on hospital wards, with cleaners, with everybody. So that's where I'm coming from.
Sarah, that's wonderful. And when we come back to the big group, I'd love you, if you're up for it, just to land a couple of those summary points back, just a couple of snippets on it. Bizarrely, I think the weekends on the ward, so I do as a general pediatrician weekends, I prefer them because they're better for conversation. People are dressed a bit more relaxed. It feels like just less stuff happening, and they're a wonderful time to sit down. This idea that we're just people, and your bit about introductions, I'm absolutely obsessed by it. If I've got 12 people on a ward round, I will introduce them to every single patient, every single one, not expecting people to remember names, but to make your message. And I love how you're influencing it. Come back in, and then we're going to get everyone back.
Can I quickly just say, sorry, it's so wonderful to have this opportunity. I was talking about it something yesterday. Again, I'm talking about it all the time. So my other point is on ward rounds, you know, doctors coming around, talking at times not to you, but about you. Please, can we not have doctors get on that stool, you know, sit on a stool or the chair beside you. Now, can I say, research has proven that it doesn't make ward rounds longer, but patients' perceptions are much better because they feel they're getting that contact. And can I say, to the leaders sitting here, and I think you probably all are leaders, lead the way on it. Because when I was last in hospital at Guy's, great care in London for a bit of something or other, I desperately tried to get the doctor. I said, well, shall I get out of bed and stand? Because, you know, we're all at different angles. And that made him sit on my chair. But then when his boss came along, he quickly jumped up, and she refused to sit down. Very lovely people, no problem. But
you're so Sarah, listen, you'll be so proud of. Listen, I'm 6'3". You don't know that because I'm sat here and I look after kids. This is a big problem. And interestingly, I started my week this week. My first thing on Monday is I was teaching. We have a new consultant induction. It's a wonderful thing. Hey, guess what I was talking to them about? Kindness. This is mandatory at our organization. We've got 14 cohorts have now gone through it, and they get Tim, the chief exec, talking about culture. They get an hour and a half of me, they have to listen to about kindness. But listen, we got in a discussion about exactly this, and it's about, with permission, sitting on the end of beds. Now, I had the director of infection prevention control in the room. We had the most gorgeous conversation. Clearly, if somebody's got profuse infective diarrhea, probably not a good idea to sit on their bed. If I've got a young person who's got mental health issues and is in there, with their permission to sit down, slow down, to not give the impression I'm off. totally critical. Listen, you and I could talk forever. We better get the others back. So let's do that. Have a breather while I just get everybody back. Just to say, because they'll all come crashing in, and then let's have a little discussion about where things are. Dom's even come to join us, which is always wonderful. Dom, hello.
Hello, I'm on the move and I got very delayed. I'm sorry.
I mean, you've missed an absolutely epic conversation, but the joy of it is we record it. We're just bringing everybody back, and thanks so much, everyone. What a wonderful little conversation.
Awkward. Are we being whizzed back?
You are being whizzed back. I'm afraid you're being whizzed back. Hello. The merry-go-round. The lovely thing for me is I get I can see Sebastian. I just saw Christina. I've not seen for a while. Listen, pop yourselves on mute if you can, because we'll get all sorts of feedback. Just drop yourselves on mute if you can. If you've got cameras, it's always lovely to see you. Well done, everyone. Fantastic. Now I'm looking around. Teams is doing that thing where I'm about 9 pages around things, which is never good for me to try and see who's around. Let's see if that improves things a little bit. Rich, where are you? Rich is there. He's top left of my. Rich, your presentation and your questions set off so many amazing discussions, and in fact, I might ask Sarah, do you want to kick off from a little bit of feedback from our group? But what I'd love to hear is from some of the groups, what's going on. As ever, let's put some stuff in the chat. I've got my wonderful friend Anne O'Connor, who can give me a wave in the corner. And we even talked about the Monday morning kindness teaching came up in things. But Sarah, it was so lovely to meet you. Do you want to say a quick hello and just talk about a couple of things we talked about in our group? You've got a couple of big pitches for people. Oh, you're on mute. Come on.
Yeah. Gosh, I won't remember all this. But anyway, so hello, everyone. I'm Sarah Turl. I'm actually a patient, and I've been a 14-year patient of our wonderful NHS through, first of all, a breast cancer, and now a standalone incurable non-smokers lung cancer. So I've had 14 years of this. Totally believe in everything Rich said. But from my point of view, what I always do is I look at staff as people. How can I expect staff to look at me as a person if I don't look at them as a person? So, you know, I want to be treated with kindness. I show kindness. I treat people as I want to be treated. And I work together with staff. It's do with me, not to me, together. Respect what I can bring to the table, as Nigel's father, I think it was sort of bringing his thoughts and everything, and that was taken on board as well. To me, the most powerful instant building with a patient and a member of staff is the hello, my name is. Hello, my name is, verbally and visually, please, like visually as well. Firing. Just so important that you have that, because everybody should always know who they're being treated by. But the stress that goes from people the minute that introduction is there. It used to be like the old shaking hands. So I do that. I do speak to staff. I love getting to know, like when I'm off to hospital tomorrow, I'll be asking everybody how they are tomorrow. When I go in, they'll be saying, how are you? And I'll be going, oh, how are you? And, you know, how's this going? Did you get your holiday away and all that sort of thing? So it's seeing everyone as individuals, as people. I did just say about ward rounds, which I'm very pleased Bob is doing something like this, is ward rounds. Engaging with people in your bed. Please come and sit down at my level. Last time I was in hospital, I was saying, you know, should I stand up? Because I don't like being at this differing level. And there was reticence. The junior doctor did sit down, but then when his boss came round, he jumped up. And I just think, by the way, there is absolute research, I think it's from Sweden, that ward rounds where you sit down doesn't take longer. and the patient's perception of their care is much higher. But I think everybody who talked about how kindness was absolutely, whether it was Lucy as a staff member or Nigel talking about his dad, everybody was talking about how powerful little nuggets of kindness are and how they can set off your day or, you know, or what have you. So, you know, thank you, everyone.
Sarah, you've done a beautiful job of pulling together things. There was loads more to talk, but let's hear from some other groups. Just one other comment. There's some beautiful stuff going on in the chat, and actually, Sarah, thanks very much for your piece that's going on. We have there's an unwritten culture where anything that feels helpful, anything that's free for people to access, please go ahead and put it in and sort of link on. We sort of stay clear of commercial stuff or things, but if it's free and open for people, put it down. You'll get people from this wonderful community joining. This amazing things. Come on, let's have some hands up. I'd love to hear from another group or two about what sorts of conversations you had in response to Rich's amazing presentation. Come on, who's going? I've never seen this group so quiet. There must be something going on. Who's going to come in?
Bob, I can't find the hand, so I'll just chat. Sorry, somebody else.
Please do, come on in, yeah.
Well, one of the things that we talked about just from my work, because I think the context for this evening was about physician burnout and its impact on patient interaction. And I was talking about physician burnout and its impact on behavior with each other, which then impacts patients. So I do a lot of mediation and conflict work with teams, and when physicians are burnt out, they're mean-spirited to each other, as you know, as well as not so available to patients, and that seemed to ring quite a few bells in our sort of group. I don't know if anybody wants to add to that.
Thank you so much. Well, such a powerful observation, and of course, care more and more being delivered in multidisciplinary, you know, complex care. Those relationships are so key. And really interestingly as well, I think there's something about how we not just tackle the issues where they're poor, but how do we really promote them? So one of the spaces, relational spaces, I'm got very interested in is the relationship as a hospital-based physician with the primary care based physician. So one of the best investments I've made over 15 years is getting to know 160, 170 local GPs, local primary care physicians, properly getting to know them at a relational basis. I love this first question. We've got too many first questions on my ward rounds. I say to people, who's your GP? And they tell me, and I smile. I say, "Oh, I saw them last week." And what you're doing there is creating a sense of connection at a time where people feel there's so much fragmentation. So some really, really lovely things. Anyone else in Linda's group? Anyone else want to come in? Rich, while people gather their thoughts, tell us about the group you were in, and where's your thinking on what you've been hearing from everybody so far?
Sure. Well, it was a wonderful conversation, and I think one big question was, where did this idea that healthcare professionals should refrain from self-disclosure come from? And I think the answer to that, it comes from the 19th century view of objectivity, that somehow there is an objective world independently of our being in it. And I think over time that has given way to a much more dynamic view of clinical reality as something that's co-constructed or co-produced, to use Paul's term, jointly by a clinician and patient. So I think there's been a natural evolution from this idea of objectivity and the idea that if you inject yourself into a situation, you're somehow making it less subjective. And the more modern idea that it's the relationship that counts, and simultaneously creating clinical reality. And we really had a nice discussion around that. and also talking about ways in which you can transform the situation. Just to put it in a word, if you're not part of the problem, you're part of the solution. And some of us who are a little bit older on this call will recognize that as a quote from Stokely Carmichael. And I think it's true. If you're not willing to act in a situation to transform it, then perhaps you're part of the problem in the situation. And I also think that we need to be kind to ourselves and not say the patient's responsibility is X, Y, and Z. And I think there's a lot of variation in how people respond to their own suffering. And we're talking about a way of transforming a situation, but not necessarily the way of transforming the situation. And then just to come back to what you asked before we broke, I do think that many of us were not as thoughtful as we might have been in terms of what we taught young healthcare professionals, because we didn't see the results years later. But now that we have seen the results, I think it's more than high time to transform the clinical encounter into more of a human and relationship-centered encounter than we have in the past.
And Rich, I'm going to, and just a heads up, Romilly and Gabby, I'd love to bring you guys in on this because it's a conversation we've had. So I'm worried, you know, the thing people talk about that it takes 17 years to translate research findings into clinical practice. I'm worried as an educator, we might be even longer than 17 years. So I worry that our educational practices, even though Rich, you've described, they're so slow to change. Romilly, Gabby, come on, you guys have been, well, are still involved, have been in sort of life as med students, as early years of being resident doctors and things. Come on, are you going to give us loads of hope to say this one's all sorted and things? Or Gabs, are you going to come first, and then let's hear from Romilly too?
Yeah. It's a no. I just firstly on why we do this. I think Rich, you're right. The other thing I was saying that I think I've heard from very well-intentioned tutors is kind of this idea of a finite amount of empathy to give, and so that in giving empathy and caring for your patients, you don't want to give too much of yourself, and I think that extends into when patients ask about you. So I don't think it's that people are being told no longer to show themselves or to like hold off, but I think it's this idea that if you connect too deeply to your patients, the day will kind of drain your energy out of you slowly. And I think it's moved away from that objectivity point to being like, you can be a person, you can care for people, but it will eventually drain you. And how do you balance that? Has it changed? Admittedly, I left my medical school as they were doing a curriculum refresh that I know has now focused a lot more on doctors as change makers and as individuals. And I met some medical students yesterday that had come into Parliament that were like really thinking about this. They'd come in to watch about it. But I think it's a bit tough because I see medical students being in the hospital environment around me where I don't think we're necessarily role modeling what we'd expect, what we're saying on this call. And I think that's the hard part, because as much as you can tell someone to give and to open themselves up and to be open to patients, they're still seeing a system that isn't. So I think it will move a lot faster if we're able to kind of change the system they're working into one that's not really high pressured and draining people, which is the impossible task, Bob, obviously. But yeah, I wonder what Romilly's gonna.
Yeah, Romilly, come and pick the baton up on that. What's your take on it?
Yeah, so I'm actually on that new curriculum that Gabby mentioned. So I'm a final year at the moment. I'm the first year of the new curriculum, so we were the guinea pigs for it. I think there's been a lot more focus on kind of like your professional values and communication and all of that that kind of stuff, which has been brilliant. I think we had a really interesting conversation in my group at the start about this kind of take on things from an educational perspective, and what are we teaching people and what's appropriate and where do you draw the line. And I think for me personally, it has always been a situation that I would love to be able to share a personal experience with a patient and connect with them on a human level and say sort of, I understand what it feels like. I understand your situation. I relate to it, and I get what you're going through, and to kind of give that reassurance. But then at the same time, I'm not sure that I, especially as a medical student without much experience, would feel comfortable doing that. Or would I worry that I was going to say too much, get myself into trouble? And I think I completely agree with Gabby about role modeling, because the situations where I've sort of questioned it and thought maybe I could sort of give something to connect on a human level is where I've seen someone who is a consultant or a reg or anyone who's kind of senior to me share their own experience. And I thought, well, actually, that was a really lovely moment. They didn't give too much. It didn't feel unprofessional, but they connected with someone, and kind of seeing someone else do that would then give me the confidence to do it myself. Whereas I don't think right now I'd feel confident initiating that, just because I don't have the experience. So I wouldn't know if I was crossing a line.
Romilly, thank you so much. And I know the wonderful Rich will want to come back in on that. I just want to highlight, Rich, before I pass back to you, and Nikki Macklin may well want to come in. Nikki, you've put something in the chat that's super interesting about the change, perhaps between sitting behind a bedside, a table to next to. There's a really interesting tech angle here around the role of ambient and ambient AI. And there'll be people on the call who are infused. So we're doing some really interesting work. I got into a great conversation where I was talking about the evaluation and the benefits and the measures, and they were all talking about time and money and stuff. I was going, no, that's a rubbish evaluation framework. You need to think much more broadly about this, and got into this space. So I think the role of ambient AI potentially could unlock a huge amount of this and allow people to sit on the floor or sit on the stool, as Sarah was saying before, and in a way document these conversations in a way that historically we've been lured behind a desk. Let's just check in. Rich, let's come back to you. I'm going to pop to Nikki, and then we're going to finish on the hour as we always do. Rich.
Well, I just want to say what a thrill it's been to be able to engage in this conversation with so many thoughtful people. And I think that this idea of asking people to engage at a human level and to say something about themselves, so that it's a more even playing field, is one that I think has great potential and great purchase. I also want to say that there's good evidence to show that it doesn't take longer to demonstrate these behaviors. And that's important, since so many people are concerned about the amount of time that they have with patients, or patients have with healthcare providers. But I'll turn it back to Nikki.
Rich, thank you. Nikki, you've just put something unbelievably brilliant and profound that is a sort of summary of your PhD in one chat piece in the chat. If anyone has got access to the chat, do have a read. Nikki, come on in, and then I'll wrap things up.
Right. Well, thank you, Rich. You're thought-provoking as always, and the way that you do it is so gentle and thoughtful. I think you get the best out of your audiences with the questions that you ask and the commentary that you provide. Yes, I was just making the point, and there's a whole school of different thought on this, and feel free to disagree with me. But the point being that empathy is a broad range of emotions. So it's not just linked to suffering or sympathy or pity for another person. And yes, I think, especially in healthcare, we do have a limited supply of that type of stimulus to suffering. And that does take a big emotional toll on us. But empathy is also linked into more positive emotions, such as joy and happiness, wanting to see someone else succeed. So and those experiencing those emotions, those are what keep us going. That's what keeps us going when we turn up to this call, is sharing each other's joy and building positive connections based on positive emotions. So I did just want to kind of flag that empathy sometimes gets narrowed down to the negative emotions, but it's much more than that, I think. And secondly, there is also a component of kindness which doesn't have to be linked strongly to empathy. So we can choose kind acts on a cognitive level, knowing that something we can do can help another person, so we can be of some benefit. That can happen at a thoughtful or cognitive level. It doesn't always need to require a deep emotional resource or connection. So those were my 2 cents. And yeah, that's really it. Bob, I will hand back to you because you're a master of paraphrasing and summaries. And but yes, Rich, from me, thank you very much for being here today and sharing your beautiful stories and wisdom.
Nikki, there's no chance I'm going to try and summarize Rich's stuff. Just to say, Rich, a huge thank you. What a wonderful, wonderful session. And Maureen, I love your comment. I think nailed it, Rich. It was inspiring, but also deeply, deeply practical. And what I love as well, it's such a beautiful community. You know, Romilly, your absolute honesty and about where and how you're thinking about things, the beautiful encouragement coming in that, quite frankly, I'm taking as well. It was sort of directed towards, and I think there's so much, Rich, for us to go and test and practice. There's lots of improvers on this call, and that's the bit for me that's really exciting. Is sort of bounding into work tomorrow morning. Is that feeling of what can I test and try out here, and I think that feels really key. 2 really quick final things. One is I'm really struck as well, Karen, Sarah, you put some events and things you guys have got coming up. Thanks so much. Good luck with them. It's really helpful as well to hear from people who are going and doing stuff and what the impact is and what the learning is. I had the privilege of being part of a group up at a thing called NHS Providers, all the providers in the UK, and we had effectively a panel around kindness and culture, mainstream stuff. Normally this stuff is tucked away, standing room only, really, really impactful piece. So there's more and more of this stuff going on. Do let us know, because I think there is power together in hearing about the different places these are being tested and how we're influencing. And on that note, it is not totally confirmed, but I'm working away on our December session, no rest for this group, 19th of December. I'm hoping through some really interesting conversations around the back that we're going to have a very direct opportunity to influence the thinking around a 10-year health plan in this country, but it'll apply to everyone's healthcare systems. So please pencil it in next time round. I think there's a really important mission to do. There's far too much what Julia Unwin would call the rational being talked about, and we need to really land some of the relational. So in a month's time, I need your help on that one, and we're going to have an opportunity to really genuinely influence how people are thinking about policy over the next 10 years. So that will be fun. In the meantime, let's bask in the glory that was an hour with Rich Frankel. Rich, thank you so much for your kindness. Thank you to everybody who's come on the call. And Rowan, what a great little piece around things. Yeah, people can put in and put a piece. To be quite honest, if you don't work in the NHS, please contribute anyway, would be my proceed until apprehended bit. We'll pull together some summary and some notes around things with thanks to Rowan and team. Have lovely evenings, mornings, rest of days. We'll catch you all soon. Take care.
Bye-bye.
Thanks, Bob.
Thanks, everybody. Bye.